Greetings, everyone. I would like to present you our concept of artificial intelligence-oriented public health in cancer care. In the last few years, the amount of required information for oncological specialists critically increased. Due to the big amount of information and the complexity of multifactorial cancer screening, diagnostic, and treatment, it's very hard for the oncologist to stay updated with the latest data and the important discovery in this field of study. At the same time, artificial intelligence technologies are already involved in the healthcare industry. The problem is that AI is only task-oriented and represents separate tools like recognition of the images with malignancies, analyzing or prediction using the big data, etc. Our aim is to study the possibilities to change this and to simplify the doctor's life. We conduct a literature review that employs systematic search strategy across the academical database from 2010 to 2023. Inclusion criteria prioritize peer-reviewed articles discussing the integration of AI in public health models for cancer care. After the evaluation of the collected data, we started to create an AI-oriented public health model in the cancer care that followed the patient from his first contact with a doctor till the end of his treatment, maximally trying to excluding the doctor from this process. For this, we propose to create 3 different AI units. So here you can see our first level, first organizational level, which is the regional AI or RAI. Regional AI is designed to interact with different basic and physical functional units of the healthcare process. The first one is the PFUS. It's the unit which consists who make cancer diagnostic or cancer suspicion, like general specialists, family doctor, surgeons, and the patient itself. The treatment component is realized by the health structures that are combined into the functional physical unit T. The diagnostic component is realized by the different type of laboratories and the healthcare structure designed for this. All of these are combined in the PFU-D. RAI or regional AI will collect data about treatment and diagnostic process from PFU-D and PFU-T. The scientific data about the diagnostic and the treatment models will be collected by regional AI from different sources like scientific journals with high impact factors, governmental guidelines, scientific meetings like we have now, yeah? And all these sources create the last PFU, the PFU-DTM, which stands for a data treatment model. So regional AI will provide PFU-D and PFU-T with those guidelines and the patient-based instruction. We propose to create a system that will generate these diagnostic and treatment models automatically without human interaction from scientific papers and other information sources generated by humans. This first organizational level of this system should be realized at the patient interact level. So RAI system will be used in small administrative units at the primary level of the healthcare organization in such institution like primary health centers or smaller institution. In this way, the ecological, climatical, social, economical factors will be considered, and this gives the possibility to treat the subject not only in the individual form, but in consideration of the regional diversity. The aim of this level is to collect patient data at the first time of cancer diagnostic or cancer suspect and to provide the patient with the necessary information. After the registration in the system, the patient must be provided with a special system communication tool, which may be presented in the form of mobile application or special designed smartwatch. This communication tool task is to provide patient with necessary notification about the treatment, drug taking, medical staff visit, and diagnosis schedules on the one hand, and in another is a possibility for regional AI to monitor the patient status and collect necessary data. The first level guides the patient through the diagnostic and the treatment process by connecting him with two additional physical units. So the examination laboratory unit with diagnostic component and the treatment procedure cabinets like surgery rooms with treatment component by sending notification to communication tool and or email. These two units are designed to collect and analyze the necessary patient health status and diagnostic conclusion and also to store the data. The diagnostic and the treatment outcomes should be supervised by regional AI. In the case of reduction of treatment effectivity, regional AI should trigger special processes that lead to a redesign of the treatment or diagnostic procedures generated by the general AI based on data from other regional AI of the system. The recommendation about the treatment diagnostic design performed by regional AI is collected from the PFU DTM. Now let's move forward to the second organizational level, which consists of general AI and the scientific AI. General AI should collect data from many regionals AI, supervise the healthcare process by generated by those regional AI, and send information to humans. All collected data from regional AI will be encrypted and depersonalized and transferred to general AI. General AI has a bilateral connection with the scientific AI. Scientific AI analyze all findings and operate with different structure in order to perform clinical trials and generate new hypotheses. This second organizational level will be based at the state or country level or another administrative unit. The main task of this level is to operate with data from all the regional AI at the same time. General AI is the general control unit of the second organizational level. It will be responsible for collecting diagnostic and treatment data from all the regional AI, summarize the diagnostic treatment model that regional AI generate, and verify the recommendation for each region. General AI will be the source of information for governmental structure, small scientific groups, or big pharmaceutical companies. It can be improved with a special interface that will give special access to the crucial data for above described units. Governmental structure responsible for the healthcare will be able to access statistic data of diseases, summarize information about the effectiveness of treatment programs, and the number of drugs needed to maintain a secure and a stable healthcare environment in the region and in country at all. The access guarantee for scientists will give the possibility to operate with different forms of statistic data. The authors of scientific guidelines that inspired the regional AI to create the diagnostic treatment model will be able to monitor the effectiveness of the finding in the way to create new or optimize the existing guideline. The pharmaceutical companies will be able to access the information of their drugs, the effectiveness, manifestation of side effects, number of drugs used per each disease or per each patient in the treatment process. In that way, companies will have a special opportunity to understand better the needs of the healthcare process in result to create new drugs and to perform new clinical trials. We understanding that this approach can influence a lot of ethical and human questions, but our main idea is to make medical specialists more free from routine jobs by saving the high quality of cancer care. We hope that AI will not change doctors and other specialists, but will take its own place in with touch contact with the human. Thank you for your attention, and also thank the organizational committee for the opportunity. Thank you.
Thank you very much, Dr. Hovornyan, for introducing us to the world of the applications of AI, not into treating cancer, but into detecting it and into tackling this as a public health challenge. There are, of course, a lot of questions and a lot of intricacies in this topic, but I believe that adopting such a model would take time, and some units or some demographics will be more privileged and will have access to this kind of public health management of cancer data while others will not. Would such a system have interoperability between units that already have access to AI cancer management systems and units that still work with the conventional manners.
Yeah, yeah. The idea is to create an environment, a real environment, like not to change the one that exists, but to create an additional one to help the patient to have a better understanding what he should do next, what drug to take, and the doctors to have easy access to the patient and to monitor the patient. And also we have a lot of troubles in the cancer care when we just lose the patient. We don't know where is the patient because the patient doesn't need the treatment or the patient don't want to come to the hospital. In this way, we have the better way to communicate with the patient with special tools, and also we have a better way to control the process. If we find some minor derivation from that decreasing of the treatment, we can react very easy.